but to follow Judy's dialogue on the endocannabinoid system, that is medical cannabis, medical marijuana, I want to talk to you about neuromodulation and the potential of cannabinoids, particularly in treating autism. Where do I point it? There. Let's see, where is the monitor at? This is not working here. You want to go ahead and advance it for me? I'll just tell you to advance it. Please advance it. Go back one, back again, back, that's it. I practice general neurology and neuropsychiatry clinically, and I also do clinical research. I've been fortunate to be the principal neurological investigator for 70 clinical trials for the pharmaceutical industry. But what I want to share with you today is some of my own research on a novel delivery for which I've been fortunate to get 7 patents in the US and abroad with others pending. This is where I practice in Sarasota, Florida. Anybody been to Sarasota? Wow, a lot. We just got again our Siesta Key Beach, best beach in the USA. In an audience like this, I know there's a whole spectrum of knowledge in terms of neuroanatomy, neuropharmacology, as well as the cannabis history and science. So I want to cover everything so I can get from basics so everybody's on board at the same level. Let's talk about the human brain first. First of all, it controls every human function, including thoughts, emotions, intentions, behaviors, and processing and interpretation of sensory phenomena. It's 2.5 pounds of the most complicated substance known to man. Consists of 80 to 100 billion neurons. That's a primary cell, which is an electrochemical cell. To give you an idea of what 80 billion, it's about 10 times the world population crammed into that brain. And it serves as the main computer for processing and outputting of nerve signals for the body's functions. Amazingly, it has plasticity, which means capacity for reprogramming and for reserve. We seem to be over-designed, which is a good thing because when you deal with kids, there's potential for them to get better from where they're at. The brain utilizes chemical and electrical processes to perform its functions. Chemical transmitters, and you know these, serotonin, dopamine, norepinephrine, acetylcholine, and others, are released at the neural synapse, which is a gap between communicating neurons and nerves. Neurotransmitter binding at the synapse results in the action potential, which is an electrical impulse, which causes neurotransmission. And neurotransmission is the basis for the function of the neurological system. Here is a neuron, and it has many dendrites, but it has only one axon. The axon is the means by which it communicates with another neuron. Now, the axon has myelin, which allows it to transmit impulses faster. So if we were to look at the end of this neuron's axon at the synapse of the communicating neuron, we would see the synapse right there. Here's the sending neuron, here's the receiving neuron, and there's a gap called the synaptic cleft. And the first process in neurotransmission is that these little vesicles containing neurotransmitters, norepinephrine, serotonin, have to go across the gap, bind to the receptors, then you get the action potential. So abnormalities in brain chemistry, as you all know, can cause certain disease states and symptoms. Lack of dopamine can cause Parkinson's disease. In fact, Parkinson's disease is caused by lack of production of dopamine in substantia nigra. Lack of dopamine can also cause symptoms of chronic fatigue syndrome. We know that deficiency of acetylcholine, the neurotransmitter acetylcholine, in the mesial forebrain causes memory loss and symptoms of Alzheimer's. And we all know that serotonin and norepinephrine loss can cause depression and anxiety, as well as a greater perception of pain. It turns out physical pain and emotional pain, which is depression, go hand in hand. The same brain chemicals subserve both of them, norepinephrine and serotonin. So when you're depressed, you feel pain more, physical pain more. When you have physical pain, you have more anxiety and depression. Symptoms of ADD can be treated by increasing norepinephrine in the frontal lobe using such things as methylphenidate, which is a CNS stimulant. Increased dopamine in certain areas of the brain can cause psychosis and OCD behaviors, such as addictions and gambling. Similarly, abnormal electrical activity in the brain, because the brain works by electricity and neurochemistry, can create specific symptoms. This is a gentleman in his 60s who was a veterinarian, and he'd had a stroke on the left side of the brain, and it was causing right upper extremity focal seizures, motor and sensory. So here's the baseline EEG, and there's that left frontal seizure focus right there, causing his symptoms. Similarly, here is an 8-year-old boy with absence seizures, or called petit mal seizures, where he would suddenly stop what he's doing and then come back. This is a classic EEG finding in that condition. In fact, they show this on the neurology boards, 3 per second spike in slow wave seizure focus. You see that, you say absence seizures, classic treatment is Orantin, or ethosuximide. And I'm going to show you later what we did with this kid in terms of treating with CBD. So altered brain function as the basis for autism symptoms. So signs and symptoms of autism suggest problems in brain processing and output of abnormalities in brain neurochemistry and electrical function. This can be reflected in the EEG, electroencephalogram. The EEG is an objective measure of the brain's electrical activity. It's measured through electrodes placed in the skull, but recall that a normal EEG does not indicate that there's not an electrical problem, as episodes such as seizures and other abnormal activity may be episodic. Here's an EEG where we wire up the patient just in the scalp, and we can see electrical tracing. As the brain works by electricity, you can see that it all comes and converges on the EEG in certain patterns, certain normal patterns, certain abnormal, and seizure foci. In fact, this is an interesting article that just came out in March 2017. Brain electrical activity was predicting clinical response to lithium. In other words, patients with bipolar disorder that responded to lithium had a certain abnormal recording in the EEG that predicted they would respond to lithium. It's very interesting. Let's switch gears and talk about endocannabinoids. And I'll be upfront with you. I was an unbeliever, and now I've been enlightened. I was one of those stigmatized traditional doctors who, it took one kid and my wife to convince me. I mean, okay, you guys who are married know the influence of wives, right? But let me just give you a little background on this, okay? We're always concentrating on the phytocannabinoids, the plant. But, as was said by Judy last talk, we make endocannabinoids, and we have endocannabinoid receptors all over the body, particularly for me in the brain. And this is the gentleman, Raphael Mechoulam, from Israel at the Weizmann Institute in 1992, discovered endocannabinoids. We knew that there were some effects of the cannabis plant on us, and we didn't know how it was happening, but he discovered the endocannabinoids, and he termed it anandamide, which is Sanskrit, which is Indian derivation for supreme joy. They asked Dr. Mechoulam, I met him last April at the Harvard Research Institute, and they asked him, and they said, Dr. Mechoulam, why did you have to go to Sanskrit to get this term, of supreme joy? He said, we Jewish people aren't very happy. so we had to get another term. He also coined entourage effect, which I'm sure you've heard of before, that different cannabinoids have different effects, and when they come together, they have an enhanced effect. And then, of course, we have synthetic cannabinoids made in the lab, such as Marinol, which is around 15 years for nausea and appetite, which the FDA allows, but does not allow this. And we're going to get into how that happened. This is Dr. Mechoulam giving a talk in April 2016 at the Harvard New Medical Research Institute. And this is what he said. Physiological systems and conditions affected by the cannabinoids. Look at it all. Anxiety, appetite, blood pressure, bone formation, cerebral blood flow, digestive system, emesis, immune system, stress, neuroprotection, movement, memory, inflammation, others. It's no wonder that Big Pharma is concerned. There's no other neuroactive compound that can do all that. When I first heard about this, I said, that can't be true. That's snake oil. There's nothing in all my research. Most of the drugs either block or stimulate, but this does everything. How does it do that? I'll tell you. This is basic. Cannabinoids are chemical compounds on receptors that act on receptors on cell membrane. Lost my voice. Cannabinoids are chemical compounds, neuroactive compounds, that act on cannabinoid receptors on cells and influence release of neurotransmitters. We heard about neurotransmitters, among other functions in health maintenance. THC is the primary psychoactive one and gives the, quote, high. CBD, cannabidiol, is the major constituent of cannabis and is most responsible for the medical effects. There are over 100 different cannabinoids that have been isolated with varied effects, giving this, quote, entourage effect. Potential medical uses. Cannabinoids have a wide scope of medical applications as they influence, among other things, neurotransmission, very important in my work. Immune function, important also. MS is immune disease. Inflammation, pain, cellular homeostasis, and maintenance. Cannabinoids are uniquely different, as I said, from any other neuroactive chemicals because they modulate. We heard the term modulation with Judy many times. What is modulation? Webster's defines it as changing or adjusting things within a system, for us, neurological systems, so that they exist or function in a balance or proper function or amount. That's why they have such varied effects. They don't merely block or stimulate. What are the physiological effects? Cannabinoids produce physiological and behavioral effects through interaction with specific membrane-bound receptors. Two types, we talked about that, C1 and CB1 and CB2. More may be existing. CB1 is primarily the brain. Basal ganglia controls movement, limbic system emotion, hippocampus memory. They're responsible for euphoria, anticonvulsive, for seizures. CB1 and CB2 receptors in the periphery system are also anti-inflammatory for pain relief. So here we go back to the synapse, receiving neuron, sending neuron. And here are the neurotransmitters that are involved, norepinephrine, serotonin, dopamine. And look at this. The cannabinoid receptor influences upstream of the neurotransmitters, influencing neurotransmitter release. These are the concentrations of CB1 receptors within the brain. Here's the chemical structure of CBD. So CBD is the, quote, medical component of cannabis and hemp. As a serotonin receptor agonist, it stimulates serotonin. It has antidepressant, anti-anxiety, and neuroprotective effects. CBD modulates the opioid receptors. We make endorphins, which are the same places where narcotics work, but CBD modulates opioid receptors involved with pain perception, and this is where narcotics and endorphins work. CBD is not psychoactive, relieves seizures, inflammation, and nausea. It prevents the short-term memory loss, which can be associated with THC. You heard Judy how she was doing a little bit too much THC and messed up some work. She could have used some CBD there. Antipsychotic effects of CBD represents potential for treatment for schizophrenia, which is a very difficult condition to treat. Potential medical uses. CBD was shown safe and well-tolerated alternative in a double-blind study for schizophrenia, comparing it to an atypical antipsychotic emulsified in acute paranoid schizophrenia. CBD and the antipsychotic both worked, but CBD has significantly fewer side effects. Studies show CBD decreases symptoms of social anxiety and isolation. Could that be useful for our autism kids? CBD has antidepressant effects in animal models of depression. Here's the medical uses approved in the US and Canada. There was an oral CBD preparation which received orphan drug status for treatment of Dravet syndrome, which is severe myoclonic epilepsy. Sativex, which Judy mentioned, is an aerosolized mist 1-to-1 ratio CBD, THC, RSO, Rick Simpson oil for MS-associated pain. And then there's a synthetic Marinol we talked about. Now, interestingly, as I said, I've done 60 clinical trials for the pharmaceutical industry. When they do a drug trial, they only go for one indication. But we know that a certain indication has a certain potential to treat other diseases. So it makes us as physicians, difficult in terms of what the package insert states and what the FDA states is the indication. A good example is Depakote, valproic acid. You've heard of Depakote? I remember about 15 years ago, Depakote rep came to me, and Depakote was indicated for seizures only at the time. And I said to him, Frank, you won't believe this. I had a patient with a head injury, and he was having these anger episodes and headaches, and I used Depakote on him. His mood stabilized, his headaches went away. He said, don't tell me that. It's not indicated. And now we know it's indicated for bipolar because it's a neuromodulator as well in terms of release of decreasing seizures. And seizures are nothing more than irritation of neuronal discharges, which depending on the location of the brain can be mood swings in the temporal lobe, headaches, or true seizures. Let's go back to the history and the science of medical cannabis, because as I said, this represents my own personal journey, and I want to share that with you because I don't know where you all stand in terms of understanding the history and the science of medical cannabis, but to understand it gives you a perspective on how you can apply it into your own practices and uses. This was in June 2015, National Geographic. It says, Weed, the New Science of Marijuana. I just want to tell you that before 1937, we never called it marijuana. We called it cannabis. Marijuana was a derogatory term for Mexico, used to demean the compound, the plant. And so it says here, there's really nothing new about cannabis. It's been around humankind forever. It is true. Here's a history, a time log. The first record in literature of the medical uses, potential medical uses for cannabinoids and cannabis was in 4000 BC's China. Then in 1860, the US came on board and started using, in fact, 1860 was the first clinical conference in the US on cannabis, international conference. Then there were 100 scientific papers between 1850 and 1900 worldwide on cannabis. 1937, pivotal year, Marijuana Tax Act. They levied a huge tax for use and basically killed the drug, killed the compound, and then 1941, it was removed from American pharmacopoeia. In other words, no evidence of it, pharmacies, literature, anything. Okay? Then, of course, now we have a resurgence because traditional pharmaceuticals, and I'm a very traditionally trained doctor, have not met the needs of our patients. And we began experimenting with for desperate cases with marijuana, cannabis, and we started seeing effects. This will surprise you. 1850 to 1937, that pivotal year, was the golden age of medical cannabis in America. In fact, these are cannabis-containing products made and marketed by US pharmaceutical companies, big pharma, for many kinds of uses, okay? In fact, we were using cannabis indica, right here, Indian cannabis, indica, and Americans being very, very good at business and innovative, they said, we're not going to get it from India. We're going to grow our own cannabis americana. So Eli Lilly introduced Prozac and Cymbalta. Upjohn Park Davis is now Pfizer. They joint ventured in Greenfield, Indiana, bought a farm and grew cannabis americana. Okay? And now, of course, they don't believe in it. What happened? What in the world happened to a drug? You're right. What did you show them what you did? Yes. That's very unfortunate. Okay, it puts people like us in a very frustrating position because there's a disconnect. What happened? And what is patent number 6630507, issued in 2003, entitled Cannabinoids as Antioxidants and Neuroprotectants? It was issued to U.S. Department of Health and Human Services, claiming exclusive rights for use of cannabinoids to treat a wide range of diseases caused by oxidative states of stress such as Alzheimer's, Parkinson's disease, stroke, heart attack, Crohn's, diabetes, and arthritis. So the U.S. government has this patent, but in 1937, they enacted the Marijuana Act. In 1941, removed it from the American Pharmacopoeia. What happened? Well, if you know history, 1935, alcohol prohibition was lifted. So we had ATF, alcohol, tobacco, firearms, and now E for explosives, without a job. The head of the ATF was Harry Anslinger, who was a believer in cannabinoids. And Harry said, you know, what are we going to do? We could just dissolve ATF, and Congress and some politicians and people said, no, we're going to pick on cannabis. And that's what happened. And so he was wrangled, and Harry was, and he was head of ATF at the time, which was in charge of regulating cannabis. In fact, the U.S. government categorizes controlled substance category 1, like heroin, cocaine, and LSD. Controlled substance category 1 says, of no medical use and highly addictive. Okay? And it's illegal under federal law. In fact, I have a lot of colleagues who want to use cannabinoids, CBD, but they're afraid the feds are going to raid their offices. And because we have DEA licenses. And I told my Dan, you've got to use your own judgment. We all have levels of paranoia and levels of comfort. For me, I'm using it because it's changing lives. Not only that, I'd be happy to stand up in court and say that. And with a lay court, you know, they can't fight it. Besides, here is that patent. Why do they have a patent on substance categorized as legal? Yes, sir. Oh. Did I lose my microphone? I'm going to do something here. Is that better? Okay. Good. Here's the modern era of medical cannabis evidence of efficacy, 1990 to present. 60 peer-reviewed studies of medical cannabis. Look at the conditions it treated, okay? 68% positive. As I told you, I do clinical trials. If you get 68%, that's pretty good. Look at the varied conditions: ALS, bipolar, cancer, glaucoma, HIV, Huntington's, so forth and so on. The evidence is there. It's being suppressed. So this is from that National Geographic article. So we have a resurgence of a compound after thousands of years of history out of clinical necessity. That's the bottom line. This shows you some of the medical marijuana breakdown by qualifying medical condition. Chronic pain leads the use. Nausea, cancer, PTSD. I've done a lot of work with PTSD in vets. Muscle spasms, seizures, of course, are very debilitating, especially in kids. And of course, Charlotte's Web with Charlotte Fiji was the one that brought it to light. And I thank Sanjay Gupta, who was also traditionally trained like me in neurosurgery, and CNN with his Weed 1, 2, and 3 series. I said, if Sanjay says that, I got to look into this. So there are people out there who are making a difference. Let's talk about my own clinical experience, which is now 3.5, 4 years with cannabinoids. I practice neurology and neuropsychiatry. The two go kind of hand in hand because brain chemistry influences how you feel. We're boarded by the Board of Neurology and Psychiatry, and I used to think, why do I need to know psychiatry? I'm a neurologist. Well, guess what? 60 to 80% of patients that come to neurology practice have a psychiatric condition, which is a brain chemical condition. So it's not that, you know, they can't handle life. It's just the way their brains are wired and the chemistry. So I had to teach myself neurochemistry. Cannabis medicine, a case of desperate needs versus inexact science. Moving to Colorado, here we are, land of hope and healing through cannabis. These cases of desperate cases of seizures, 50 to 100 seizures daily, traditional medications making them zombies, not working them, families having to sell their businesses, their homes, and moving to Colorado to take such compounds with these crazy names like Poison, King Bubba, and Kamikaze. So I said, we need to get some science into this thing, you know, and some credibility, because it's all over the map. So how did I become a believer? In life, sometimes, don't you find yourself believing something is the way things are until there's a pivotal example or case? This was my pivotal case. And I'm glad I was open to it. Let me give you the history because it's important. I was speaking in San Antonio for my migraine product, which is also in the back of the neck. And the drug rep who was taking me around, Cynthia, said, "You probably won't see me again." I said, "Why not?" "We're moving to Colorado. We're moving to Walsenburg, which is right south of Colorado Springs." I said, "Why?" "Well, my son Alan, who's 22 at the time, was run over by a truck at age 14 with intractable seizures. He had 5 brain operations. There he is, brain operations. And intractable complex partial seizures with secondary generalization so that he'd be out of it for 24 hours, forced to drop out of college, becoming depressed, contemplating suicide. Evaluated in Dallas, Texas, where I went to medical school, at the epilepsy center, they said, "You got multiple foci. You're not a candidate for surgery or for a vagal nerve stimulation. Just try the meds." He had been on Dilantin, Carbatrol, Keppra, Lamictal, Depakote. He came to me on Vimpat and Onfi with this history of seizures every month. And he wrote a letter to me, which I shared with my wife, and it was heart-wrenching. So my wife said, "You got to do something." I said to Cynthia, "Bring Alan to Sarasota, stay 4 days. We're going to do EEG and workup. I'm working on a topical CBD preparation. Let's see if it works." Well, this is June 2014, seizure-free 3 years. And he's using CBD cream in the back of the neck twice a day. He remains on Vimpat, but his Onfi's been cut in half. His repeat EEG showed no more seizure potential. He's doing well, graduated college in May of 2017, wants to go into politics, make a difference. In fact, at his graduation at Abilene Christian College, I think class of 800 or so, the dean made him stand up and they gave him a standing ovation because they didn't think he could make it. It's changing lives. Here's another example of a changed life. I think I showed you this one, the absence seizure focus. You see that pattern, you can say that's absence seizures. This was Aiden. Aiden is 8 years old, and he began having these drop attacks and these episodes where he'd just stare and then come back. He went to the pediatric neurologist at All Children's Hospital, which is part of Johns Hopkins in St. Pete. They did the EEG, and sure enough, the doctor said, "You've got absence seizures." And the mother said, "What do we give him?" Ethosuximide. Being a astute, smart woman, she read up on it and said, "I'm not giving my son that. I want CBD." And he said, "I don't prescribe it. There's a guy down the street in Sarasota who does." I didn't know I'd be a pot doc. But anyway, so Aiden came along, and this was the baseline EEG, okay, in my office. What I like to do is hook up patients to the EEG monitor, show the baseline, and show their functioning, right here, abnormality, and I put the cream on. 5 minutes after, look at the EEG focus. 8 minutes, it's gone. And he's been seizure-free now for about 1.5 years, 2 years. Here is that stroke patient, the veterinarian with strokes. He had to give up his practice because he couldn't use his left hand. It was shaking all the time. I gave him CBD, and oops. and the seizure focus is gone. So he's on that now. He's back practicing veterinary medicine, and he's using it on his animals, and it works. Here's another case, Keaton. Keaton was riding a bike, fell off at school doing painting, and dropped his paint and everything, and we got the EEG, and there's a seizure focus right here. It's due to this thalamic hamartoma right here in the brain. After CBD therapy, the focus is gone, and he's been seizure-free now for a number of years as well. So all those things said to me, there is something going on here that works quickly, effectively, and is making a difference. But I didn't know much about Asperger's autism, and this was my pivotal case with autism. This was JT. Look at the history. It'll tell you why he was doomed for some problems. 21-year-old Asperger's with anxiety, impulse control problems, and problems with the law. Okay? He was adopted by elderly parents at birth. They were already in their 60s. And he was diagnosed with Asperger's at 7, tried on Ritalin for his attention deficit problems, Risperdal for his outbursts, Depakote for mood stabilization, and Lexapro for memory, all without benefit. He attended college for a year, then technical school, and dropped out. Couldn't do it. He was living alone. His parents said, "You're 21, you need to live alone." So he was living in Tampa in a bad section of town. And he was getting more and more anxious because of the paranoia and the area that he lived. So the psychiatrist gave him Xanax time release, 2 milligrams, 2 to 3 times a day for anxiety and paranoia as needed, which is a hefty dose. So living in a bad area of town, he bought a handgun from his biological mother's husband. What was he thinking, right? He ran out of Xanax from overuse, began having difficulty concentrating, and suicidal thoughts. Called up his psychiatrist. Psychiatrist said, "Go to the pharmacy, I'll call it in." So he went to the pharmacist, and the pharmacist denied the premature Xanax refill. But he said, "I need it. I ran out 24 hours ago." He wouldn't give it to him. He came back with a gun and said, "I've got a gun. If you don't give it to me, I'm going to do something." And he refused, so he discharged the gun in the ceiling twice and was arrested. Okay, he's 21. In jail for 3 months, he gained 20 pounds eating junk food and released on bail, given biofeedback sessions, but no meds. So he started smoking cannabis, and it started helping him, okay? So his father called me, and his father's lawyer called me and said, "Can you do anything? He cannot help these episodes of impulsivity. We know he can't." And they're holding him accountable for that. So, in my initial visit with him, he was inattentive, easily agitated. He was not delusional, psychotic, or combative, though, but obviously agitated. So I gave him some CBD cream, 3% the back of the neck. In 10 minutes, he became calm and stated, "I'm thinking more clearly." I said, "Really?" My impression was autism with loss of insight and social skills with panic attack and encephalopathy from Xanax withdrawal. So I said, let's do an EEG, consider CBD on a regular basis. We may give you also Lamictal for mood stabilization. But you gotta stop smoking cannabis because it's illegal. So here's JT's EEG. You don't have to be an EEG expert to know that's a burst of high amplitude sharp waves. Now imagine your brain is going along nicely and all of a sudden this happens. Depending on how you're feeling or what part of the brain this is doing, you might not be feeling very well. You might be impulsive, you might lose self-control, so forth and so on. So this kept on going every 15 seconds. Here is 10 minutes after CBD, it's gone. And so we prescribed it for him, and he was able to get off his charges and given a new chance at life. So the human endocannabinoid system functions to maintain health and well-being. Through neuromodulation, the changing and adjusting of things so that they function in balance or proper fashion or amount. As brain neurochemistry and electrical imbalance is the pathological basis for autism and its symptoms, medical cannabinoid therapy appears to be ideal for treating it at its core. I'm going to now introduce you to direct effect CBD, which is the technology I was fortunate to discover 15 years ago and obtain patents. I started with migraine drugs first the triptans, and then to dopamine for Parkinson's, and most recently, patents have been filed for the cannabinoids. So the CBD therapeutic benefits are achieved through activity, through receptors in the skin nerve endings with direct connections to the brain. Blood and blood-brain barrier are bypassed. These are the source of side effects with traditional systemic therapies. What are the shortcomings, you know this better than I do, of current autism therapy, which are primarily aimed at symptoms and can result in long-term deleterious effects? Excessive weight gain from neuroleptics, further diminishing self-esteem, increasing social isolation, which they already have. CNS stimulants for attentional problems contribute to agitation, anger, outbursts, poor appetite, insomnia. Benzodiazepines, as you heard in JP, can cause cognitive blunting, dependency, and potential for withdrawal phenomenon. Then systemic antidepressants can alter brain chemistry and neurotransmitter upregulation in developing brains with unknown long-term effects. So this has been my workup in terms of, before considering cannabinoid therapy, and particularly the direct effect CBD therapy for autism. Do an EEG, and then apply the cream, if your physician will allow it, during it, and show the effects. Show the effects electrically as well as clinically. Do an MRI brain if the EEG shows focal abnormalities. You wouldn't believe what you find if you look. A complete metabolic workup. Thyroid, B12, vitamin D, cedrate, in addition to usual CBC and metabolic profile. I supplement with methylcobalamin, methylfolate, and acetylcysteine to support brain health, as well as omega-3 fatty acids. Then neuropsychological testing is important as a baseline, then after therapy to show improvement, because the family and the patient needs to know there's improvement. Let's go now to direct effects therapy with medical cannabinoids. This is the million-dollar question. Is there a means to minimize or prevent the potential side effects of cannabinoids, such as psychoactivity, dependence, addiction, long-term effects on personality, performance, particularly in children with developing brains, while preserving its medical benefits? This is what the pharmaceutical companies and FDA is wanting us to concentrate on. It's going to mess them up. Well, traditional pharmaceuticals are already doing that. So the answer to the million-dollar question is yes, there is. And I was fortunate to come across this technology. Direct effects therapy using neuroactive drugs, such as cannabinoids and the others, is a groundbreaking topical, meaning on the skin, therapy which treats neurologic and psychiatric conditions, including chronic pain, through direct nerve connections without limitation of blood flow, thereby providing rapid therapeutic benefits. You saw in the EEG within 5-10 minutes, without concerns of systemic side effects and drug interactions. How does that happen? When I first started doing the research and I got headache relief in 8 minutes with sumatriptan topical cream in the back of the neck, I said, how is that getting in the bloodstream? And my wife said, maybe it's not getting in the bloodstream. Take a look at the anatomy. So I did, and I got the answer. Here's the answer. Traditionally, we take drugs by mouth or injection or nasal spray, but it has to go in the bloodstream. Okay? In fact, we call that therapeutic blood level. Having done 60 clinical trials, we've done dose-finding studies, and I'll tell you, the doses that we use are underdosed because the dose that we would want to get into the brain would be so excessive in the bloodstream, the FDA would never pass the dosage. So everything we use neuroactive is probably underdosed because drugs in the blood have to cross the blood-brain barrier, then get to the brain and get to the problem. As opposed to that, direct effects goes directly and acts on nerves at the back of the neck and also in the skin through the back of the neck, through the skin into the nerve endings. How does that happen? I coined this term BONAF, back of the neck of the hairline, because it's a critical area of drug application to modulate afferent neural input. Afferent means going back to the brain. Efferent means coming back. The brain and the skin work together. So if you were to look at the back of the neck and cut it out, here is your brain stem. The brain stem is the size of your thumb. It's the master processing center. I call it a grand central station, where all the nerve impulses from the brain go through the body and from the body back to the brainstem. Look what's right behind the brainstem in the skin and the nerves. The vagus nerve is right there. That gives you all the neural supply from the head and back of the neck to the brain. I'm sorry, the trigeminal nerve. The vagus nerve is from the rest of the body. So at the C1 through 4 nerve roots make up the components of the trigeminal nerve, which merges the vagus nerve to affect all the afferent flow back to the brain. Well, let's look at the skin. Here's your skin, and this is your dead skin layer, stratum corneum. This is where you ladies get your dermabrasion and all that good stuff. And then look what's right underneath there. Free nerve ending. The first structure is a free nerve ending. Looks like a fan. You follow that, becomes a peripheral nerve. Then there are the blood vessels and so forth. So what's so special about the free nerve ending? Well, it turns out when we were embryos in our mother's womb, neuroectoderm, the embryological tissue that made central nervous system, spinal cord, brain, also made the skin. These two are the same organ. If they're the same organ, guess what? They have receptors that communicate with each other. And that's the basis for this therapy. So this is from Wikipedia. I didn't make this up. Here's the spinal cord, and here's your dorsal root ganglion, which is right outside the spinal cord. This is the processing center, relay center for all peripheral input from the outside. And there's your free nerve ending right there, which is the end component, peripheral component of the dorsal root ganglion. If you were to blow up the end of the free nerve ending, this is what you see. There's TRPV1 for capsaicin. There's CB1, CB2 receptors, nerve growth factor, and endogenous agonists. What are endogenous agonists? Well, there they are. Serotonin, dopamine, norepinephrine, GABA, CGRP, endorphins, endocannabinoids. We make all those. If we make all those and we have receptors for these, guess what? We can use therapeutic agents like CBD, tizanidine, apomorphine to bind their specific receptors in the skin. Here is your CB1 and CB2 receptors. You saw this already. Here's your cell membrane right there. Outside the cell, sticking out in the breeze, are these. Inside the cell. So when you apply CBD topical cream, it binds the CBD receptor and sends a nerve impulse. As a result of my findings, this is my initial 88 patients. Now it's over 600. This is I found my patent on this basis of using topical CBD, the back of the neck. And these are the conditions that it worked for. Seizures, epilepsy, encephalopathy. I put the arrow for conditions that could relate to symptoms of autism. Anxiety, mood disorders, insomnia, spasms and tics like Tourette's, Asperger's, autism, attention deficit, social isolation, cognitive problems, including memory, and then neuropathic pain and processing of sensory phenomena. So what is the place of cannabinoids with direct effects CBD and autism? This is from Autism Speaks. It says, I'm very sensitive to lights and sounds. In other words, since the brain controls all human function, including thoughts, emotions, and sensory processing, there's a dysfunction in sensory processing in these kids. And most of these kids are very smart. It's just that these things are holding them back. So signs and symptoms of autism suggest abnormalities in brain neurochemical electrical function, which may be reflected in the EEG. The endocannabinoid system acts to modulate many aspects of human function, including the brain. The direct effects CBD offers a safe, potential treatment without concerns for systemic side effects and drug interactions, which is a huge plus. Systemic cannabinoid therapy, even with THC, as Judy said, in combination for entourage effects, may be needed. Each person is different. You may want to use capsules, drops, sublingual forms, preferred over vape or smoking in kids, and gummies, because gummies is a little too close to, for candy and stuff. So the take-home message with endocannabinoid therapy is direct effects are not the end-all. You may want to consider, depending on your case, that we're all different. It says, we're all wired differently, so therapy must be individually tailored. What is true and works for one may not be for another. There's an element of trial and error. That's why they call medical practice. We practice. You probably probably not you, but this is for the general public. You go, I'm not ready for my kid for cannabinoids, for cannabis. Okay, I don't know how it works. It's not been FDA approved. Insurance doesn't cover it, so I'm not going to use it. Well, this is what I say to them. You may be already using cannabinoid therapy at home with essential oils. Lavender essential oil, the active ingredient is caryophyllene, which is a non-cannabis cannabinoid receptor agonist. In fact, I took a picture of the lavender oil bottle that we have at home. Look what it says here. Benefits: soothing, normalizing, balancing. Doesn't that sound like modulation to you? To end this talk, why are we doing all this? Why are we looking for therapies that we can have better outcomes for our kids? Because statistics show that if we don't get proper treatment, they get into substance abuse, okay? It says a diagnosis of autism is associated with doubled risk for a variety of substance abuses related, including drug and alcohol. Anywhere from 19 to 30% individuals diagnosed with autism abuse drugs. The reason being they're self-medicating, things aren't working, and we need to give them something that works. And in this slide right here, we're preparing them for life and for aging. So with that, I'll end. Thank you very much for your attention. If there's any specific questions I could answer. Yes, ma'am. Well, exactly. Yes, no, okay, good question. The question is this. When we use drugs systemically, we can develop a syndrome called receptor upregulation intolerance. In other words, you need more and more and more. The reason being, the blood flow does not know neuroanatomy, okay? Our nervous systems work sequentially, A to B, B to C, C to D. So when you take something by mouth, it goes in the bloodstream, it hits everywhere. And so downstream receptors are upregulated. This happens in Parkinson's all the time with dyskinesias after 5 years of Cinemet. So your question is, does this happen with direct effects? No, because it does not go in the bloodstream. In fact, the opposite I've seen, in time, they need less dose because the brain is plastic and reprograms. It could happen with oral. You know, it's hard to tell, you know, because especially in developing brains. But you know, I feel like at this point, we're using sometimes fairly toxic traditional pharmaceuticals. What do we have to lose with a natural herbal product? Our key is to get them better. Sometimes I think as parents, we think so far down the road that we withhold current treatments and things for our kids that could affect them now, which could prevent downstream things. Yes, sir. You know, being in Florida, I cannot use THC back of the neck in my technology, but I am one of 2 neurologists in the whole state of Florida certified to prescribe medical cannabis, and I have about 160 patients on it. Again, depends on person to person, and I'm not seeing any hard, fast rules. It's a trial and error thing, but some people say, you know, as you saw in the last lecture, THC has certain effects, CBD has certain effects, and the combination can have different effects. You're just going to have to try it. I prefer using CBD, pure CBD first, because it's not controlled and you know, it's safer in terms of psychoactivity and so forth. And then if things are not helped, they start adding the THC and other components. But we're working on that. Yes, ma'am. To prescribe the direct-to-X cream or direct? The question is this: am I limited in the diagnoses in terms of prescribing cannabinoids? As far as the direct-to-X CBD cream, no. No, because we are using hemp CBD, which is universally available and not regulated. In fact, I've done studies now with topical caryophyllene, which is totally unregulated because it's from essential oils of, as you saw, lavender and cloves and so forth. And that works as well. But in Florida, though, if you were to use cannabis-derived CBD or THC, you have to really jump through hoops. You got to register them to the Department of Health Compassionate Registry. They have to get an ID card, which takes 6 weeks, and then you have to renew their treatment plan every every three months, and they are only allowed 45 days worth. So really making it hard for us. Meanwhile, I can prescribe dangerous drugs like opiates just like that. And also, get this, they don't say I prescribe it, I recommend it. It's crazy. There's not a prescription. It has to be registered through the Department of Health. Oh, no, it's not by prescription. Yes, ma'am. Allergic reaction to the cream? Good question. As far as allergies, there's been a couple of cases of rash, less than 5%, okay? Maybe a little irritation, and sometimes we have to just change the base on that. It's not really the cannabinoids, and we prefer using the crystalline CBD powder. But we're working with the other cannabinoids as well, because this is a means of treating using cannabinoids non-systemically, and being non-systemic, it won't show up in the blood test or drug screens, which is a real plus. But we're still, in the learning stages. It's kind of very interesting. I feel like we're very fortunate to be living in an era where a compound of 6,000 to 8,000 years history was taken out of medical use in America, and now has come back, and now we have the technology to really make it work well. That being said, though, I feel like there's no FDA agents here, right? But I feel like the government is somewhat in cahoots with the pharmaceutical and insurance companies to hold things back for a lot of reasons. But one of them is that I think big pharma is realizing we better get on board too. And they're doing their work. They're doing their work. Yes, ma'am.
So in 2014, when the President Obama signed the Farm Care Act, he allowed CBD, as it's my understanding, as long as it's less than 50%, to be used for.
That's what it seems, okay? But many things are out there as, quote, law and signed, but each state is playing it by ear, and each state is, being as conservative they need to be. So I really can't say just because something has been signed. But the good news, this is what I heard though, the government is not really going to spend any money pursuing somebody for using medical cannabis for a medical purpose. Okay.
So, we can get CBD oil at home,
Yes.
right?
Yeah.
As a dietary supplement.
But you got to be careful what you're getting though.
Well, I'm just saying in terms of the law, right? It's in the
Yes.
law.
You can order it online.
Right.
Yes, you
So,
can.
you know,
But the thing is this, though, depending on your jurisdiction, and depending on which cop stops you, you may be in trouble. Let me give you an example. Orange County, Orlando, you can it's like a ticket if you have cannabis. But you cross to Hillsborough, you get arrested. It's a felony. So, it depends on, it's a really messed up system, and we need some order. But meanwhile, we've got patients who are suffering. So you just each person has to use their own judgment and their own level of comfort.
you in Florida, you just passed medical marijuana, right?
Yes, we did. We passed it for, thank goodness that we passed the Amendment 2, because that changed a lot. It gave physicians the opportunity to say that this was a debilitating condition, which can be a lot of things. Depression can be debilitating to some people. Before, it was just seizures and cancer and intractable muscle spasms. So it is looser in that regard in terms of availability to patients, but it is tighter in terms of the patients getting it. And what's happening now is we have 7 dispensaries. A couple of dispensaries are producing product, but they can't sell it through the dispensaries because the inspections have not cleared through. So there's a lot of politics going on too. Yes, ma'am. Exactly. This is what I recommend. If your kid's on a traditional drug, we add like CBD or some other drug. As they improve, we start removing the other one. You never want to remove what's there because you can have withdrawal seizures because the systemic effects can cause withdrawal seizures, which are worse than regular seizures. But many mothers, especially, they're very astute. Watching the kids, they go, he's better, but I think I want to get him off the Klonopin. I want to get him off the Depakote. We start doing that slowly. Yes, ma'am. Well, good question. I don't base all my clinical decisions on EEG, first of all. EEG is just another piece of data I can use to convince me and the family that something not right is going on in the electrical system and that using this drug can help it. That being said, even with regular seizure patients who give me a clear history of seizures, as I said, seizures are like a picture. I take a picture of you, you're not smiling. Does that mean you never smile? No. It's just at that time you didn't smile. So to answer your question, what we do is 72-hour ambulatory EEG. We hook them up for 72 hours, let them do life, then we pick it up. But if you think there's going to be a seizure, what's that? You got to stop. I think time's up. Thank you very much. I'll talk to you later. Thank you, man. Yeah. No, it's in the PowerPoint.
Check, check. Check.
Test 1, 2. Good morning. Thank you for coming. I wanted to briefly say something here. Almost 20 years ago, I had the opportunity to introduce my brother, Dr. Jeff Bradstreet, to the community for the very first time, and we were in Amsterdam, Holland. And there was a tremendous amount of excitement because of the amount